Good morning, respected faculties and colleagues. I'll be presenting my paper on an ambidextrous analysis of outcome of patients with mobile AAD who underwent posterior fixation with C1 C2 transarticular screws at a single institute. Introduction described by Magel and Seaman in 1987. C1 and C2 transarticular screw stabilization offers the advantage of a more rigid fixation with higher rates of fusion, avoids need for post-op halo. There is no need for placement of an intraspinal implant, and there is possibility of its use in anomalies of odontoid process or the posterior arch. Also, a fixation with a transarticular screw achieves fusion in close to 100% of the patients. However, there is significant risk of vertebral artery injury, malposition of the screw, and instrumentation failure. Also, it requires preliminary reduction of C1 on C2 before screw placement. Aims and objectives. To assess the rate of fusion in patients undergoing C1 C2 transarticular screw fixation for mobile AD, and to look for the rates and types of complications occurring in these patients. Study design, it was an ambidextrous observational study. Criteria for inclusion, all cases of AD, mobile AD who were treated using C1 C2 transarticular screw at our institute and had a minimum follow-up of 6 months. Criteria for exclusion were patients with pathology of C1 and C2 facets or C1 lateral masses such as comminuted fracture or tumors, destroying the C1 lateral masses that prevents placement of screw, or patients who had other methods of fusion like wiring or clamps. Now methodology, preoperatively all patients underwent a detailed clinical and neurological examination including looking for stigmata of CVJ anomalies, involvement of lower cranial nerves, muscle bulk, tone and power, DTRs, cerebellar involvement, sensory and ball bladder involvement. Radiologically, they were evaluated with dynamic X-ray CVJ to look for mobility of C1 and C2 vertebrae, basal invagination, status of atlas vertebra, and the reducibility of AD. They underwent CT CVJ with CT angio to look for dominance and course of the vertebral arteries, size of each C2 pass and its relation with the foramen transversarium, and MRI CVJ to look for cord compression, any changes in cord signal at the cervicomedullary junction, soft tissue abnormalities at the CVJ, and to assess the need for neural decompression. Operative procedure, patients were placed in prone position with gel bolster chest support and appropriate padding of pressure points with immobilization of head with Mayfield clamp in a slight chin tuck position. The entry point in the skin for C1 C2 transarticular is typically around C7 vertebrae, which is a small stab incision, and the trocar is tunneled into the surgical exposure, and the drilling and tapping of the screw are carried out through this working channel. The entry point is around 3 millimeters lateral to the caudal part of the C2 lamina inferior articular process junction and 3 millimeters cranial to the inferior articular process of C2. The direction of the screw was around 5 to 10 degrees medial in the lateromedial plane and around 30 to 40 degrees in the craniocaudal direction. Post-operatively, patients underwent X-ray CVJ on post-op day 1 to look for reduction of AD. CT CVJ at a later date during admission only to look for reduction of AD and the placement of screws, and dynamic X-ray CVJ at around 6 months to look for fusion and stability. All patients underwent assessment for myelopathy using the MJOA score, and neck pain was assessed through a modified ODI index, both prior and post-surgery. Now definitions. Screw were said to be well positioned if the screw passed through lateral masses of C1 and parts of C2, crossed the joint in between, and protruded through the anterior cortex by less than 5 millimeters. The screws were considered malpositioned if the screw was too short, too long, that is it protruded more than 5 millimeters anterior to the arch of C1, too high, pointing to the basiocciput, or if it missed the lateral mass of C1 by being pointed too low, too lateral, or too medial. Stability, if there were no observed movements between the posterior arch of C1 and the spines process of C2 in flexion and extension radiographs on lateral view, and the fusion was considered when there was a solid osseous fusion between the C1 and C2 bone on dynamic X-ray. Results, around 40 patients were recruited in this study, and the mean age of the patients was around 28 years with a predominance of male patients. Around 65% of the patients in the study had congenital causes of AD. The average blood loss during surgery was 240 ml, and the average duration of surgery was around 206 minutes. The average duration of follow-up was around 26 months. Cause of AD, the most common cause of AD in the study were congenital, that is I said 65%, followed by traumatic causes. The most common associated anomalies in these patients who had AD was os odontoideum in around 13 patients, followed by type 2 odontoid fracture, followed by congenital causes like hospitalized atlas, BI, etc. Now, surgical procedures which were performed in these patients, more than 50% of the patients underwent C1 C2 transarticular fixation standalone screw placement. Around 10 patients underwent C1 C2 transarticular fixation with C1 C2 Gayles wiring, and 3 patients underwent C1 C2 transarticular fixation with FMD for associated carry malformation. Around 3 patients underwent unilateral C1 C2 transarticular screw placement because of anomalous vertebral artery course in 2 patients on the contralateral side, and the breach of screw during placement on the contralateral side in 1 patient. Now, position of the screws. Screws were well positioned in around 82.45% of the patients. 82% of the screws were well positioned, and around 17% of the screws were mal-positioned. Complications. There were not severe complications in this study. Only 1 patient had an intra-op CSF leak, and the same patient developed meningitis in the post-op period, which was managed conservatively with IV antibiotics. 1 patient in this study had a surgical site infection at the iliac crest bone graft donor site. 1 patient was on prolonged ventilation following surgery. He underwent tracheostomy and was finally discharged in stable condition. And 1 patient had hardware failure. There was fracture of the transarticular screw at 3-year follow-up, but that patient had a solid fusion by that time. Conclusion: the fusion rate in our study was around 96%, which is favorable with the literature. 27 transarticular screws were put in our series without any incident of vertebral artery injury. It suggests that standalone transarticular screw is good enough to achieve a solid C1 and C2 fusion for AAD, and post-operatively patients had significant improvement in myelopathy with p-value of less than 0.001 and neck pain. The limitations of the study: the study inherently depends upon accurate recall by patients and may suffer from recall bias. The study relied on medical record data, which was missing in some cases. Also, pre-op imaging was not available in all the patients. Thank you.
Thank you, Abhishek. Nicely presented. You said this was an ambispective study,
Yes,
right?
sir.
So there was some patient retrospective and
Yes,
some
sir.
patients.
Yes, sir.
And you had angiograms on all the patients.
Yes, sir.
So the vertebral artery,
Yes, sir.
in how many cases was it lying, or it was a high riding, or the foramen was large? That has not been told in this study. That is the most important, I would say, feature
Yes, sir.
to decide whether the patient is suitable for TAS or not.
Yes, sir.
That's first. So you didn't, that data is not there.
Sir, actually, we did not have scans of all the patients who were operated before 2012, sir.
So if you, whatever scans you had a prospective part of the study.
Yes,
That's my
sir.
first question.
Yes,
so
sir.
what were the results of that?
Sir, all those patients who underwent transarticular screw fixation, they did not have a high riding vertebral artery, sir, and foramen was also within the normal range, sir, more than 4 millimeters in thickness in all the patients.
So this you have not mentioned. You are just saying we have to accept one now. What was the position of the head?
Sir, slight chin tuck position, fixed on
Slight?
Mayfield. Chin tuck position, sir.
Why
fixed
chin
on
tuck?
Mayfield. Sir,
My question is, all these are reducible ADs.
yes, sir.
In what position will they reduce?
Extension.
Extension.
Yes,
so
sir.
did you keep your patients in extension, flexion, or neutral?
Sir, initially they were placed in large chin tuck position, sir, and during placement
There
of
is
the
nothing
screws,
like chin tuck position.
sir,
It's a simple thing. Would you reduce your AD prior to starting the procedure when you put your position your patient?
yes, sir. That time only we'll reduce. We'll put
That
the
means you put your patients on extension,
extension.
complete extension.
Sir, not complete, but because we will do intra-op reduction also, sir, during placement of the screws.
We are not. See, there are. Why I'm asking is,
Yes, sir.
if you place your patient's head in extension,
Yes, sir.
which is a prerequisite for reduction,
Yes, sir.
then putting in percutaneous screws is extremely difficult.
Yes, sir.
Because your head is like this.
Yes, sir.
So there are various ways
Yes, sir.
by which usually we put a slight extension
Yes, sir.
And then how do we reduce introp?
Sir, we apply pressure, sir, intraoperatively.
What pressure?
Sir,
The answer was in your slides. If you cannot answer this, your award goes away.
Sir, intraoperatively we will maneuver the C1 C2 joint, sir, during placement
So?
of the screw, sir.
So what maneuver though, it's a reducible AD, you can
Yes,
do
sir.
anything you want.
Sir.
You will put a wire there or
Yes,
fix
sir.
it, put in anything to fix C1, C2
Yes,
before you put your transarticular screw.
Sir. Yes, sir.
I don't have any questions if you have.
Okay, Abhishek. Thank you.
Thank you.
Nice presentation.
Thank you.